Good evening, everybody. Good evening, good evening. Let's see here. Welcome. We got some new members joining already. Appreciate it. Thanks. Appreciate you joining. Last week was an unexpected open. Anybody can comment. Anybody can comment and discuss streams. So that was fun. But appreciate you guys joining. We'll let some other folks get in here. Yeah, thank you very much. Audio good, with some thumbs up. Everything sounds okay, looks okay. Fantastic, thank you. All right. Let's see here. Make sure everything's working okay. All right, we got our anatomy model going. Some more stuff. Put that there. All righty. Well, let's see. I think I'm burnt out on the Lindsay Vonn videos myself. Appreciate everybody who's followed along and enjoyed learning from it. But we'll see. I think there'd have to be pretty significant difference or change. I felt like the last one I did was a little bit repetitive, to be honest, with a lot of the stuff we'd already covered and talked about. I will say, like, it was nice to see that kind of confirmed everything we had been suspecting from the start in terms of the compartment syndrome, the fasciotomies, how everything's been going since then. But I think this is going to be the long, slow process now for her, right? There's really not much to do other than sit around and let things heal. And so this is the frustrating part of her rehab. There's not like another big surgery coming up. There's no like big thing to look forward to other than starting to put weight on it. But that's going to be a while based on everything she's been going through. So I hope those are all interesting. I did so much more Olympics content than I thought I would. I was able early on, first video got blocked, taken down from copyright stuff. So I didn't think I'd be able to really do much more, but then was able to. That's why so many of the videos, like I wasn't playing the clip, was because I knew that if I just let the clip play, the IOC, NBC was going to basically block it. And so that's why I was going through and just doing like screenshot, because I knew that if I let anything play for even just a second or two, it would get blocked. So appreciate you all bearing with and understanding that. Certainly with all the other NBA, NFL, other sports that aren't as strict as the IOC, we will continue to put as much full kind of long-term replays in there if we can. So again, anybody comments, feel free. Any new members joining in, comment section, that's all for you all to ask questions, interact here. I'm dealing with a little bit of a cold, so bear with me if things sound a little bit more stuffy than usual. But let's go ahead and just dive into some of the comments here that we had in the community page. And then I'll keep an eye on our chat as well. If anybody has other comments to join in, then absolutely put those in there and we'll get to those questions. So Steph Curry's runner's knee. Yeah, let's talk about Steph Curry's runner's knee. Let's see, was there something? Oh yeah, sorry, we'll start at the top. Jack, welcome. Thank you for joining. Happy for y'all to be here. The chat's for any members here, so ask questions away. We will get to them. DeJounte Murray expected to make his season debut tonight. Yeah, against the Warriors. Exciting, recovering from his torn Achilles. Yeah, I think, the hard, like whenever these guys have these long-term injuries, like there's such a kind of broad window during which they can return. It's not like when you have a fracture and you've got a 4 to 6 week recovery time and it's like, okay, as soon as like the soonest day you can get back, you're going to go. Something like an ACL, an Achilles, a PCL, a labrum, a rotator cuff, a quad tendon, patellar tendon. There's a pretty broad window in terms of how quickly you can get back to play. And so as long as like the time frame seems reasonable, it never really concerns or worries me whenever we see these guys come back. So, he probably could have made his return a week ago. It could be another week from now. It might have even been like 3 or 4 weeks ago if the All-Star break would have fallen at a different time. So there's such a wide range for when players can come back. So for DeJounte Murray, no concerns. Will be exciting to see how he looks getting back into things. The thing I always tell people too is remember that there's like return to play and then there's return to performance. So when somebody's coming back, like DeJounte Murray has returned to play tonight, but that doesn't necessarily mean he's returned to performance. And that return to performance is like the last step that you need to think about. And that return to performance takes much longer than when you just come back on the court. So just because you come back on the court day one doesn't mean you should be expected to be at your same level of performance. That additional return to performance is going to take a little bit more time down the road. And so great to see him back. Huge step, obviously. And then I would expect, as weeks go by, games go by, that he continues to look better, do better, gets back into his shape, etc. What kind of button down? Yeah, no button down for the streams. The streams are casual. I enjoy wearing the button downs, but I also kind of feel like now I have to wear the button downs. I've got a closet full of them over here. No, I don't just spend all day in a button down. I wear scrubs to work. So yeah, the streams are my excuse to be a little bit more comfortable, a little bit more casual. Just got a fresh haircut tonight too. Shout out to my wife who cuts my hair and does a fantastic job. So yeah, no real concerns. Anything with DeJounte Murray. Excited to see. All right, let's see. Steph Curry's runner's knee. Trump's bones burst to celebrate the State of the Union. I have no idea what this means. Yeah, we were talking about that. Expecting Garland or Morant to return anytime soon. I wouldn't. I'll be honest, I haven't been following all the Morant stuff all that close. Same with Garland. It's been such a hard NBA season, right, with what's going on with all the tanking. Like, we just saw a player for the Jazz, I think, right, that the Kings that is getting like a nose surgery. And they're like, oh, he's been dealing with it for years and just decided that now was the time to get a nose surgery. So it's hard. It's been hard to follow, like, are guys on expected timeframes, or are things being delayed because of the whole tanking problem, etc. So it's been harder, right? I mean, what are the Grizzlies playing for right now, right? If I believe the Grizzlies aren't, super high up there. And so it's so hard to predict what's going on with some of these longer term injuries and teams especially that maybe aren't doing as well. Steph Curry's, so let's talk about Steph Curry's runner's knee. Normally wears bandages on his knee, so could those be injection sites? Richard Jefferson recently said that Steph claimed it hurts to sit down on the bench. So he chose to stand most of the game to cheer on his teammates. Yeah, let's talk about patellofemoral pain syndrome here a little bit again. So this is a bugaboo to treat. Like, anybody who works in sports medicine will tell you that treating patellofemoral pain syndrome can be one of the more just frustrating things to deal with, because it's not like a meniscus tear that you can go in and do surgery for. It's not like a torn ACL that you can go in and fix and then be done. It's kind of this broad, non-specific term for when people have pain behind the kneecap. So patella, the kneecap, femur, so patella, femoral. The trochlea is a little groove of the kneecap on the femur, where the kneecap slides back and forth. And so patellofemoral pain syndrome, runner's knee, is just a kind of non-specific term for pain around the patellofemoral joint. By definition, typically there's not like cartilage trauma. Everything we hear about Steph Curry's injury is like structurally things look good. And so that would be the case. There might be some degree of like cartilage softening, chondromalacia, we'd call it, some little fissuring, like some little areas of cartilage damage. But it's not like there's something that, meets the criteria to need a cartilage transplant, surgery, etc. But it still hurts. And so it's a situation where you have pain, but you don't have like an injury, so to speak. It's not like there's a torn ligament. It's not like there's a torn tendon. You just have pain, and you've got to try to manage the pain. And managing the pain is really, really hard, because there's not like a thing you can easily inject, or like a medicine that's going to necessarily like knock it out, like an infection or inflammation. So it's just a stubborn thing. Like, a lot of it is trying to figure out how to improve his alignment, improve his mechanics, work on load. Runners tend to get it. It tends to be called runner's knee because of weakness in the glute muscles. So weak glute med, glute min muscles in particular, poor control of your quads can tend to cause biomechanic abnormalities with loading through the patella, and runners just tend to have weaker glute med, glute mins. And so it's not like this is something you just fix overnight. Like, usually this can take like weeks, months of rehab to try to get better. And so it's really stubborn. It's really challenging. It's frustrating for everybody, frustrating for the medical staff, frustrating for Curry. I will say, though, I do agree with what he's saying. Like, if this was the playoffs, I think he would be playing, because again, it's not like there's a structural trauma. It's that he has pain, and they're trying to just control his knee pain. The one thing I kind of threw out there on social media that I was being serious about, I've done this in a couple of athletes and had really good success, like more so than I would have expected right away. There's 3 nerves that send signals from the joint back up to the brain, called the genicular nerves. There's one that kind of runs here, the superolateral. There's one supermedial, and then there's one that wraps around and goes down to kind of the pes bursa. And so there's kind of a nerve coming up this way, a nerve this way, and then one that goes up this way. One of the ways we'll treat like knee osteoarthritis, any sort of knee pain, is you can do injections around these nerves to try to help block the pain signal. And that's something like you don't need to take time off. I've done it in some runners, and when we've kind of had no other options and they're just, structurally everything's fine, just really stubborn pain, and worked pretty well. And so I threw that out there on X as an option, like just do a genicular nerve block, let him go play. Because again, it's not like he has trauma or like damage in his knee. It's that his knee hurts and they're trying to control the pain and balancing how much do you continue playing, how much do you hurt, risk of other injury, that risk benefit of everything. And so that's what's going on here. Again, we're talking about Steph Curry here with his runner's knee. I don't think these are injections. I mean, I've seen what you all are talking about with the Band-Aids, right? He's always got these Band-Aids on his knee. It's not like in the classic spot that you would expect for a knee injection, and I cannot fathom that they're doing that frequent of injections in his knee. I mean, that it's like every night he's got Band-Aids there, and so I can't imagine they're doing anesthetic injections every single night. That's a lot of anesthetic exposure, and cumulative anesthetic exposure can be toxic to cartilage. So it's not like doing anesthetic injections like lidocaine, bupivacaine are completely risk-free. There's still some risk to it. So I'd be hard-pressed if they're truly like injecting his knee every night. Maybe they are, they very well could be, but I think that would surprise me. The part here about why it hurt so much to sit. When you sit, you flex and you load that patellofemoral joint. So a lot of people who have this will struggle going up and down stairs because that loads the patellofemoral joint. Anything that puts you into more knee flexion will load the joint, tend to make it hurt more. And so that transition sit to stand will hurt, not so much just the sitting itself, but the transition, sitting to standing, stairs, sitting in a car for a long time, are all things that you can definitely see. Yeah, the heavyweight boxer Joe George collapsing in his corner. Yeah, I saw this. The fact that it was delayed makes me think that it was more of like a syncopal episode, something neurogenic as opposed to like concussion. Essentially, he got hit, was on his way, was back in his corner, and he just collapsed on his stool. And so, yeah, it was definitely bizarre. I don't think this was like delayed concussion knockout. I suspect it was some sort of syncopal event. Could have been lightheaded, dizzy. It sounded like everything from when he got to the hospital and was discharged that he's doing okay. So it doesn't seem like there's been any big concerns with him. What athlete would you say you've reacted to the most for having different injuries? Lately, Lindsay Vonn, right? Just one injury. I think we've done like 6 videos on her. Long term, I think somebody on my channel counted, and it's Anthony Davis. I think somebody went back and counted, and I think I've got the most videos on Anthony Davis for different things. Early Zion would be a close second. I did a lot of Zion stuff early on, but lately he seems to be pretty healthy. I'll admit, I haven't done much NBA stuff this year, and it's not a choice. I've been obviously paying more attention to the Olympics recently. Football was super busy. I will say too, like the way I get so many of my alerts with stuff, like I'm not sitting and watching NBA every night for 6 hours. I've got more of a life than just doing that every single night. And so a lot of my stuff, I get updates on X, but like the X algorithm, if you spend a bunch of time on Olympics stuff, that's all you see. And you miss all the NBA content. And so now that Olympic stuff is done, hopefully that shifts a little back, and we'll get back on board with some of the basketball stuff. Let's see. How severe does a fracture have to be to cause swelling, increased pressure to cause compartment syndrome? I feel like I've never heard much about this until Vonn. Yeah. Not as much as you would think. There are certain fractures that are just higher risk for it. So tibial shaft fractures, tibial tubercle avulsion fractures. So kids who get Auschwitz when you're a kid and you get that like bump on your knee, that's a chronic inflammation at the area where the tendon anchors into the bone. You can have an acute injury where the tendon pulls a chunk of bone away. That's high risk for compartment syndrome. And so there's just certain injuries that we know based on the anatomy, usually injuries around the lower leg, the shin, severe kind of certain types of ankle fractures, tibial tubercle avulsion fractures. You just know that there's going to be a lot of trauma to the surrounding tissue, and that bleeding in the tissue can cause the pressures to go up. I will say too, I know Lindsay in her video, she made a very big deal about how lucky she was that her surgeon, Dr. Hackett, was out there with her in Italy because of her ACL. And if he wouldn't have been there, he wouldn't have been able to save her leg. You got to realize a fasciotomy is intern year of orthopedic surgery training. I mean, a fasciotomy is not like anything complicated to do. I can guarantee that hospital she was at in Italy had all kinds of people who are more than competent and capable enough to do a fasciotomy. And so I think the video that she put up makes it sound like it was a decision like within minutes of amputate the leg or perform a fasciotomy. That's not how this goes. Like the fasciotomy is done as the pressure is increasing as you're developing compartment syndrome. But like any trauma surgeon worth their salt, orthopedic surgeon who spent any time like in any sort of trauma can do a fasciotomy. Like it's not a complicated, wild, crazy, like heroic thing to do. Yes, it needed to be done, and doing it effectively prevented the death of the tissue in the compartment, which then prevents the infection, which prevents the loss of leg. But that's like multiple days down the road. That's not like, oh my goodness, cut off the leg. No, here comes the surgeon to save it and do a fasciotomy. There's a lot of steps in between there before you ever get to like amputating your leg. And they wouldn't have like amputated the whole leg even, you know, they would take like muscle out from the compartment. It's not like they just go in and like cut off her leg. So I understand that was a little bit dramatized, but I'm not the one who's experiencing it. I'm sure in the moment it was very traumatic. And it's always good when you've got your, you know, your surgeon that you're comfortable with who can be there in the OR helping. It definitely gives a level of increased confidence and comfort with things. So I'm glad it all worked out okay, but know that if you get compartment syndrome, it's not like they're going to debate if they're cutting off your leg in the first 30 minutes of coming in. Welcome. Thank you for joining. Please feel free, ask questions, chat, do all this for you guys. Oh, I see you have one. We will get to it here in a second. Let's see. Generalizing wildly, what does retirement feel like for elite athletes, like 60-year-olds? Yeah, I don't know. They find other sports. They play pickleball. They play golf. They find other things to go do to keep them active and keep them competitive, which I think is great. Thoughts on PRP for arthritic knees? I love it. I think it's great. I think there's kind of three main things that you can inject for knee osteoarthritis. Corticosteroids, kind of the old school. Yeah, it's going to help, but short term, not great for cartilage. Long term, can be toxic to cartilage. The second thing, hyaluronic acid. So if you saw my Olympics videos about the ski jumpers who were injecting their privates with hyaluronic acid is frequently used for knee arthritis. Lasts a little bit longer than the steroid, not the same kind of cartilage toxicity effects. When people have insurance coverage for it, I tend to recommend that over the steroid. But then I think the PRP is the best. The literature, you've got to be careful because it's very dependent on the number of platelets in the dose. And so whenever you do PRP, you draw blood, you spin the blood in a centrifuge, concentrate the platelets, which are cells in your blood, and then you inject those platelet cells into the tissue. For a knee, you inject it in the knee just like a steroid shot. But we know that the number of platelets, like the billions of platelets, matter for how effective the PRP will be. And so some of the old school, like original PRP kits were very low in platelet counts. So instead of concentrating platelets in your blood by like 5 times, they would concentrate it by 1.5 times. And so it's not equivalent to a different device, a different manufacturer or machine that concentrates to 7 billion platelets. You know, if you're getting 2 billion platelets versus 7 billion platelets, that's like taking 5 Tylenol or taking a quarter of a Tylenol. And so you can expect the end outcome to be different because you're getting a different dose of platelets. So the biggest problem with a lot of the early PRP research is, number one, they weren't reporting the platelet concentration and what was being injected. So you didn't really know. You didn't really know like what the dose was of platelets. And so some of the studies were positive, some of the studies were negative, showed no difference. There was a huge study that came out a couple years ago in one of the top medical journals that said PRP was no better than just saline for knee arthritis, but they used a PRP product that was like 1.5 times concentrated, which we now know isn't enough. You need like 5 to 7 billion platelets in order to have an outcome. So it's important that you get a proper dose of platelets in your PRP injection for it to work. Otherwise, it's not going to be as effective. Challenge 2 is insurance isn't paying for it. And so it's cash pay. Depending on where you live, the market of where you live, you're going to have a lot of different costs out there, a lot of different ways that people will do things. But yes, I absolutely think it's effective for arthritic knees. I like it for tendonitis, like chronic tendonitis, rotator cuff tears, tennis elbow, Achilles tendonitis. It's a really good treatment for tendonitis as well. Good question. Are race car drivers athletes? Absolutely. Yeah, you think of like the neck strength to be able to sit there in a race car and control things. Yeah, I mean, even like e-gaming, right? I mean, carpal tunnel syndrome, like metabolic issues, obesity, etc. There's a lot of stuff with different types of athletes just because they're not, skiing down the hill at 90 miles an hour doesn't mean they're not any less of an athlete, just a different athlete. All right, welcome, new member. Let's see, thoughts on 65 game limit for NBA awards. I get why they introduced it, but it significantly increases risk of injury. Yeah, I understand why they introduced it, and I think they had to do something, right? I mean, you've got to have some threshold, some limit of like how valuable you can be for your team if you're not available. I think we just need to decrease the season length. I think that's the solution, and I don't think it's a mystery. I think everybody agrees that the season's too long. I think what probably is going to start to happen is the NBA awards are just going to become kind of meaningless because the players who probably deserve them aren't going to meet the criteria for them, and then everybody in time will start to be like, it doesn't really matter. And so I think they'll unfortunately start to lose their meaning because players that maybe would be deserving of them won't get it because they missed by a game or two and had some terrible injury, but otherwise played well. So yeah, it encouraged players to play through things, which I will be honest, like to some level, you need to be able to play through things, right? We'll talk about the whole Darren Peterson situation for Kansas. At some point, you need to be able to play through aches and pains and bumps and bruises, as long as you're not doing it in a way that's causing things to progress and get worse and worse and like lead to longer term problems. So it's a balance, right? Like you're not going to expect everybody to be completely pain-free, completely symptom-free in a sport that's as hard and aggressive and violent as any professional sport. So yes, I think it'll lose its meaning. I think ultimately we just need to decrease the season length, change back-to-backs, etc. Yeah, what do I practice? So I practice sports medicine. So my primary residency, my primary specialty is physical medicine and rehabilitation. PM and R, physical medicine and rehabilitation. And then I did a fellowship in sports medicine, and now my job, it's kind of a combination of non-surgical orthopedics. I work in an orthopedic group, but trying to focus on sports medicine within orthopedics. So I still see, an average day of clinic. I'm in clinic 5 days a week. My kind of average 18 to 20 patients a day. Of those, maybe 3 to 5 of them are like, quote, athletes, like young high school, college athletes. The rest of them are just like you and I, everyday folks, old, young, that have shoulder pain, knee pain, ankle pain, fall on the ice, break their wrist, that sort of stuff. But you can get to sports medicine a lot of different ways. You can do surgical sports medicine, so orthopedics, and then a sports fellowship and do, ACLs, rotator cuffs, etc. I am non-surgical sports medicine, and you can get to non-surgical sports medicine through family, internal medicine, emergency medicine, pediatrics, physical med and rehab, neurology, and internal medicine. So yeah, this is often an example I use with hyaluronic acid. I tell people like, oh yeah, it's in face moisturizers, and then they say, oh yeah, I've seen that written down on things. How common is athletes at all levels with weight management problems after they finish playing the sports? This is a big deal in football, especially. In fact, it's been a really big deal with offensive linemen, defensive linemen in particular in football, because they have to work to keep their weight on. Like they have to eat crazy amounts. They have to try to stay big. And I don't care how strong you are, a lot of those like offensive linemen that's not healthy, right? It's not healthy to be 400 pounds with a huge gut and like crazy high body fat. I don't care how tall you are. That's not healthy. That's not healthy long-term for your body. And so it is a real thing. And I think lately the NFL has tried to do a much better job of like managing that post-play general health, like high blood pressure, diabetes, cholesterol, prostate stuff. Like there's all the other general medical things we forget about, but affect these guys when they get into their 40s, 50s, and post-retirement. So I think a lot of them actually lose the weight, which is good, but it's important, I think, that they do try to lose the weight, right? Like Warren Sapp. Like Warren Sapp was not like a healthy body weight to be at. And so it's important when players retire that they try to get to a better, healthier body weight. Absolutely. Yeah. Yeah, I mean, I think a lot of it is that they're trying to eat more and put on weight, especially in those certain positions. The ones that aren't overweight, right? I mean, they're super cut and fit and athletic and shredded and like great, keep that up. So, the pacemaker question. Yeah. Nebraska basketball coach claimed his cell phone could stop his pacemaker. What kind of pacemaker is that? Okay, so I got to be careful here. I'm not a cardiologist. I'm not an expert on pacemakers. I find it very hard to imagine that a company would design a pacemaker that a cell phone could brush by and change. I mean, like a lot of these pacemakers you can communicate with them through a cell phone. So you can connect to it through an app on your cell phone and you can interrogate it. You can, change settings. You can get information about how the pacemaker is working by connecting it to a phone. So a phone is not like intrinsically harmful to a pacemaker. I saw this. He kind of like swatted at someone, right? And then you try to come out after and be like, oh, I'm like nervous because if something gets near my pacemaker, like that's it. I mean, like, come on, dude. Like, there's cell phones all around you all day long. Like, you're talking with your phone right here. It's not like you're putting your phone in pacemaker mode. Again, don't quote me on that. I'm not a pacemaker expert. Could he have some specific thing that cell phone? I don't know. Sure, but no, it's not like companies are designing pacemakers that if a cell phone like comes within 3 feet of you, it's gonna like shut off your pacemaker. Like, right? That would be the dumbest thing in the world. So I think he was just trying to come up with an excuse. That is my honest opinion, and that's what I'm here to do, is give you my opinion. Gummies with hyaluronic acid, I would imagine ingesting them would lower the same thing with all this like with like collagen supplements, glucosamine, chondroitin, etc. Like the amount that you're actually going to get absorbed in your gut that's going to find its way into your bloodstream, find its way to your arthritic knee, make any bit of a difference, I think is hooey. I think it's like entirely placebo effect. I tell patients with all these like joint health supplements, try it for a month. The worst it's going to do is affect your billfold, as long as it's, like not some gas station glucosamine or whatever. But I wouldn't encourage people to spend a ton of money on it long term, because it's not going to get through your stomach acid. It's not going to, make a difference that way. High energy shockwave treatment for Achilles tendinopathy. I understand it's done in the OR. So you are probably thinking of something called, let's see, let's pull this up and I'll kind of show you guys what I'm talking about. Let's show you some more. So if we're thinking of the same thing, so like this ESWT, extracorporeal shockwave therapy, this is not done in the OR. This is something that's done like in clinic, like with you awake, and can be extremely effective for tendinopathy. Yeah, it's like, I think the original premise for it came from what they'll use like lithotripsy to break up kidney stones, where sound waves are like shot into the kidney to help kind of break up the kidney stones. It's the same concept, but applied to soft tissues. And there's a ton of like really good benefits for it. I love it. It's a non-invasive way to help manage annoying tendinitis. Excuse me. That's really good for in-season athletes, because other ways to manage like chronic tendinitis, plantar fasciitis, oftentimes if your basic rehab, equipment modification, footwear, etc. is not working, you're getting to like needle-based procedures. And those needle-based procedures tend to have downtime, right? Where you're not, PRP for someone's patellar tendinitis, you're out for 6 to 8 weeks minimum. And so Shockwave, you need to generally take a little bit of downtime, a day or two before you're doing a lot of explosive stuff, depending on, specific protocols. But there's minimal to no downtime. There's no incision. It can be a little bit uncomfortable. And there's some contraindications, pregnancy, medical devices, speaking of pacemakers nearby. But yeah, there's a ton of benefits for it. And so I think it's great. Also, though, not typically insurance covered. So a lot of places are cash paying for it, which makes it harder to find, because it's a big investment for a physical therapy group, a sports clinic, to spend money on a Shockwave machine. But yeah, if you have access to one, it's been offered to you. Definitely has very good literature behind it for treating tendinitis. So yeah, good question. Process for acute management of open fractures. Get them to the hospital. Yeah, get them to the hospital. I mean, so if to be honest, I've never had an open fracture when I've been covering sports. I've had plenty of fractures, but never an open or a compound fracture. So if someone comes in, gets smashed in the leg, their shin is popping out of their skin, what would I do? I will try to, if possible, sometimes you can very clearly kind of realign things, right? Like try to do some attempt at a reduction, or you kind of roughly try to get, if your knee's bent at 90 degrees, if you can like easily put it back straight, try to put it back straight. I will then, if we have some sort of like betadine, like antiseptic solution, douse it in that, cover it up with as clean of a towel as you can, get them immobilized, get them to the hospital. They're going to need washed out. Like if you've got a true open fracture, bone exposed, you're going to the OR, it's going to get washed out in the OR. And so you're just trying to do the best you can. You're trying to do the best you can, get things realigned as optimal as possible. Put some disinfectant antiseptic solution on it if you can, if you've got it. You're not going to hurt anything. If anything, maybe you'll help kind of kill a little bit of bacteria getting in there. And then get them to the hospital as quick as you can. Don't futz around in the field trying to do anything heroic. My job is to just get them to the field. Now, if someone's got a dislocation, like let's say it's a fracture dislocation, then you're going to try to reduce it. You're going to try to realign, a compound fracture dislocation of an ankle joint, for example. You're going to try to get the joint reduced, hold it in a good position, splint it in a reduced position, and then get them to the hospital, because the more things are hanging out, it can pull on nerves, pull on blood vessels. So you would try to reduce it if you had a fracture dislocation that was open. Let's see here. Yeah, it's tough. You were asking the questions about weight management and stuff after football. Yeah, because you're put in this position where like you're supposed to be big, right? And your body adapts and changes to that. And so yeah, it's hard. Thoughts on high intensity laser therapy? As a PT, I found them to be very effective for acute sprains and strains as well as tendinopathies. I'm curious what you find effective about them. I'm skeptical, to be honest. I'm skeptical. I don't think there's a lot of great research out there. If you have anything, please pass it along. But I'm skeptical about it. I think too, it's really hard because like, what's the average time frame for an ankle sprain, right? The average time frame for an ankle sprain might be just like a couple weeks. And so how do you really know if you're speeding up the recovery when it's just going to be a couple weeks anyways? I think it's really hard to say. Now, if it's not crazy expensive and the athlete likes it and it gets them to buy into other stuff, it helps with their pain, it helps their swelling. Okay, cool. Like I can buy into that. What I can't buy into is somebody who shows up to a PT clinic and just like gets laser done for $1,000 for, 6 sessions and like doesn't do anything else. So it's hard. Like that's the hard part with all this cash pay stuff is what's the literature there to back up someone spending their cash on it. PRP, we've got good data. It's cash pay, but we've got good data. Shockwave, it's cash pay, but we have good data. This laser therapy, the red light therapy, I guess I have not seen any overwhelming data that makes me convinced I would spend a bunch of money on it. Depends on how expensive it is. And also, right, you've got to just think about the natural course of healing. And so how much are you really speeding along the natural course of healing in something that might not be that big of an injury? I think about this with all modalities, to be honest. They're great, and I think in certain doses. Again, though, right, I'm not there. I'm not the one doing the rehab, so I've got to be respectful of that. And I don't tell athletes they can't do it. I kind of leave it up to the PT, and if they ask me about it, I tell them my opinion. But a lot of that I would defer to the folks that are doing it regularly, but just kind of my basic thoughts. Welcome. Thank you for joining, new members. Hopefully you're asking some questions. Yeah, we got some questions down there. Let's see. Could I get epicondylitis from pitching? The last 2 times I've thrown, I've had a really bad arm pain. Just hope it's not UCL or something like that. Yeah, let's go pull up some pictures in the elbow. Let's see here. There's that. Let's move that comment. Yeah, so let's talk about elbow tendonitis. So epicondylitis, medial and lateral epicondyle. So up in the elbow, the medial epicondyle is this rounded contour right here. The lateral epicondyle is the outer one. And there are tendons that come off of those epicondyles that go down to the hand. So on the lateral side, it's your extensor tendons. So your extensor tendons, the tendons that wrist up that way, straighten your fingers out, comes off the outside of your elbow. The medial side is the flexor tendons that do the opposite. So they curl the wrist up, grip. And in the setting of a baseball player or throwing athlete, what lives right underneath the flexor tendon is your UCL. And so your flexor tendon, we talk about, let me get that out of the way. we talk about active and passive stabilizers of joints. The UCL is a passive stabilizer of your elbow joint. So when you're throwing, your UCL is not changing in the moment, right? It's not contracting, relaxing. It changes over time, but it's a passive structure to stabilize your elbow. The overlying common flexor tendon sitting through here, that is an active stabilizer to help stabilize the elbow. It's not uncommon for athletes who are at risk of a UCL injury to have some initial flexor tendinitis because there's some evidence that you're overloading that inner side of the elbow. The flexor tendon can be the first thing to start to go and develop pain, tendinitis, etc. If that pattern continues, the next thing in line to take the impact is your UCL. So any medial elbow, inner elbow pain in a pitcher, you got to take seriously. If it's lingering, it's getting worse. It's not just because of the flexor tendinitis. It's that can be a sign you're overloading your elbow, and that overload can lead to the UCL, having an injury. Yeah, you're an MRI tech. Yeah, exactly. So like a lot of pacemakers connect to the phone. So I can't imagine how like a phone is going to harm a pacemaker. So I don't know. Maybe that someone's going to like hack his pacemaker. How would I treat your bursitis? Using a walker, having a lot of pain. Yeah. I'll kind of comment. I try to not do like personal medical advice on these again, because I don't know your full situation. I will say that the big thing is that it's not typically just bursitis. It's usually more the tendinitis, and finding the right type of PT is key for these. I do injections for them. I do injections of steroid when nothing else works to try to just help with the pain, but steroid shots honestly aren't a great thing long term. PRP is a great thing for this long term. I would say if you can, try to find a sports medicine doctor near you, a non-surgical sports medicine doctor. If you're struggling to find somebody, go to AMSSM. AMSSM is the American Society of Sports Medicine. And I believe somewhere in here, there should be a link. Yep. Find a sports doc near you. So go here, amsssm.org. Type in where you are, and it'll give you references to sports medicine doctors near you who can help talk through like other options to treat this beyond just like what your orthopedic surgeon or your family medicine doctor is going to do. Because it's stubborn. It can be really difficult and frustrating, but there are a lot of things to try, and sometimes these need surgery. It depends on what your imaging looks like. There's a lot of factors to it. So I can't tell you exactly how I would treat it without knowing more details, but find a sports doc near you, a sports medicine doc. Non-surgical sports medicine doctor is going to be the best place to start with that. Let's see, where did my mouse go? Oh no, my mouse died. Let's plug this back in. Mouse died. There we go. Mouse is back. All right. What else is here? Do avulsion fractures usually heal on their own, or do you have to anchor them back down with fixation? I've seen both. Yeah, so depends on where it is. Most do not need surgery. Most avulsion fractures do not need surgery, but it depends on where it is. A tibial tubercle avulsion fracture in a kid who can't straighten their leg, yeah, that needs fixed most of the time. Like a pelvis avulsion fracture, a rough guideline is like greater than 2 centimeters of displacement. Maybe talk to a surgeon, but I've yet to see a surgeon actually fix one. A lot of places you'll see little avulsion fractures around the ankle when someone sprains their ankle instead of just ligament tearing. The ligament kind of pops off a little fleck, right? People are, oh, I got an ankle fracture. No, you just have a little fleck avulsion. Those don't need tacked back down. So it depends on how big the bone chunk is and how displaced it is, and then what your subsequent function is. If it's a big tendon, like triceps tendon, pops off the back of the elbow, you can't straighten your elbow, yeah, that probably needs fixed. If it's a little tiny fleck around a joint from a ligament, no, it doesn't need fixed. Yeah, we try to give some resources though here. Yep. Let's see. I think did I answer that, your question, Catherine? Oh yeah, Shockwave. Yeah, that's fine. Yeah, no, that's okay. I think we addressed it. No problem. No problem. Let's see. Does attempting reduction outweigh the risk of worsening the fracture? Yeah, it's like you want to know what you're doing when you're trying to reduce a joint. You don't want just anybody who's never done it like cranking and pulling on a joint, because you can make things worse. Generally though, like if you're doing it in the right way, no, you shouldn't be worried you're going to make it worse. Now, the difference there is, let's say you're trying to reduce a joint and you can't reduce it. So a shoulder, I try once, can't get it in. Try a second time, still can't get it in. You could have a fracture in the joint, and the fracture in the joint is preventing you from reducing the joint. So you shouldn't just keep trying, like cranking, pulling, because you can have an irreducible or an unreducible joint because of trauma to the joint that's physically blocking you from reducing it. So generally, like a shoulder, I'll try twice. I might try a third time or have like a partner try a different way. Elbow, I'm going to try once. If I can't get it in once, chances are I'm not going to get it in a second or a third time. So it kind of just depends on your comfort, how things are feeling. You never want to like aggressively force things. Joints generally want to go back in place. And so all you're trying to do is encourage the joint to go back in place, which is what it should want to do. If it's not wanting to go back in place, that usually means something is there blocking it. Sometimes even like the finger, like a finger that dislocates and can't get back in, tissue called like the volar plate can get stuck up underneath there and cause problems. So even something as simple as a finger might not be reducible. And so you got to just don't sit there and kind of quit jamming it. Let's see here. Yeah, you're right. Yeah, I mean, honestly, I'm not trying to dodge the question. I truly you need to find a non-surgical sports medicine doc, because we're going to have the most training to understand your x-rays, your MRIs, potentially utilize ultrasound, understand what your rehabs look like, if it was good, if it was bad, the role of injections. It's not a simple, just black and white problem to treat. It's a very complex, hard problem to treat with a lot of nuance to it. And so everybody's situation is different. Some people truly do need surgery, other people absolutely not. It depends on your imaging, your exact, occupation, risk factors, age, comorbidities, etc. But I can tell you that a good non-surgical sports medicine doc will be the best person to help you manage it. My question on chiropractic, is that like a quackery pun? I think it's fine for certain things. What always kind of discourages me a little bit is when I have patients who come in and they've had months or years of hip pain. And they're like, oh, I go to a chiropractor every week. Yeah, let me guess, you're not better, right? I think there's some good data out there for low back pain and how it can help with management of low back pain. Beyond that, I don't think there's much. Again, it's part of a multidisciplinary rehab approach though. And so we've got a chiropractor for our team at school. They definitely can make a difference, right? Players are dealing with some back tightness, some soreness. If a chiropractor can help get them feeling better without medications, without drugs, without shots, great. Please, by all means, do it. Where I'm less positive on chiropractic care is joint problems, right? Like someone who's got a sprained ankle, you need a PT. A chiropractor alone is not going to help your sprained ankle. So it depends on the situation. I'm very much against the high velocity manipulations. There's no benefit whatsoever to getting your neck cracked. Cool, you feel better for a day. Is it worth the very, very, very slim risk of something happening? To me, no. But that's my 2 cents on it. Yeah, the laser question. Conjunction with other therapies, exercise prescription. Yeah, so I think for a role like this, I think it's fine. I think it's fine if you're using it as part of a complex role. I think it's the same with PRP though. It depends on how you market it too, right? If you're marketing it as oh, this is gonna, grow your tissue back, and this laser is gonna heal your Achilles, and I think that's inappropriate. But how you're describing it here, point here, I think is great. Using it as part of a multi kind of modality approach overall with their care, fantastic. Take advantage of resources you have. Again, I think there's harm to it. The harm is if you've got somebody who can barely afford their $40 copay for PT, and then you're trying to upsell them on $800 of laser therapy. That to me is the harm, and that you just have to rely on having good ethical people in the field. Let's see. All right. Any suggestions for someone looking to learn anatomy, whether it be textbook, courses, videos, etc.? Watch my videos. No, for real though, I think if you can apply functional anatomy to things, I think that helps, right? Because you're trying to think of what's underneath the skin, what's in the structures, what's going on in the background. And I think that can help. This biodigital anatomy tool that I use over here, it's free, right? Just go human.biodigital.com. It's free, and you can cruise through, look at anatomy, and try to correlate with what you see clinically. So if you're seeing a patient with knee pain in clinic, go pull up your anatomy book and look at the knee. Understand the structures around the knee. Where does somebody hurt? Somebody hurts here on the elbow. Okay, go look at an anatomy book and learn about what is here, because learning about what is here will tell you what could possibly be hurting, which will then guide your evaluation. So don't just like try to rote memorize it. Try to connect it with what you're doing clinically. Use these 3D models. Like, these 3D models to me are everything. Like, without these 3D models, I'd have a such harder time. My skeleton back here, right? Like, get things to visually help you have that spatial awareness of where things are, and then correlate it to your exam and your clinic stuff. Yep, good question. Yep, love it. Helps them do the rehab, not too painful toilet loading. Perfect. Yep. Yeah, you're welcome. Yeah, absolutely. What's up, regular? Welcome. Patients with pacemakers were told to avoid microwaves. The early cell phones probably emitted stronger signals than they do today. Yeah, I don't know. Maybe he's got just like a super old pacemaker that hasn't been replaced. Can't go near a microwave. That would still be kind of bizarre, but... yeah. Let me look at one. Let me find... I'm going to find one other resource here. Let's see. Greater. Yeah, Katie, I'm going to give you one other resource here that you can go and look at. So what I think has the best like study out there on this condition, greater trochanteric pain syndrome, is this paper right here. I think it was called the LEAP. Yeah, the LEAP trial, LEAP. Education plus exercise versus steroid versus wait and see for gluteal tendinopathy, greater trochanteric pain syndrome. Really nice prospective study, blinded, randomized control trial. It's free. You can find it. You can read the whole study here. I'm not, showing anything that's behind a paywall. You can read this whole study. It'll give you links to other studies, with all these AI tools. This is a great place to start in terms of like understanding the condition, understanding some of the basic treatments, but more importantly, understanding some of the exercises. So what I give my patients in clinic for an exercise program comes straight from this. I have it made into an exercise program that I can give them if they can't do therapy. So the LEAP trial, greater trochanteric pain syndrome, the LEAP trial. I'll have this up here. You can go back, pause, Google that. Another good place to start. Yeah, that sharp piece on her x-ray. Let me pull that up here real quick. No, it shouldn't cause problems, to be honest. The only time, every fibula fracture that I've seen clinically, surgeons are never excited to touch. And the reason for that is the perineal nerve. So sometimes by going in there and mucking around in the area, you can actually make the nerve worse. And so let's see, where is her x-ray picture in here? Yeah, there we go. So this little sharp guy right there. If she had shown up for surgery and she couldn't bend her ankle, her nerve was damaged, they would have gone in there and tried to free things up and evaluate, kind of manage the nerve, potentially being injured. But if the nerve is functioning fine, they leave them alone. It kind of surprised me too when I was first learning about these. They leave it alone, because if you go in there and put a plate on it or anything, you just cause more scarring and fibrosis and inflammation and can make that nerve unhappy, which can cause more pain. But still, she hasn't really clarified if there was any nerve damage at all. So that would be an unknown thing to still consider here along the way. Absolutely. You are very welcome. Yeah, carotid dissections. Again, that's why nobody's cranking on my neck. I can try some other things. Fellow fan of the pit. I've thought about this. I just need to figure out how to handle the use of footage, to be honest. I don't know. We're far enough into this that I'm not going to go back and change anything with the stream, to be honest. I'll turn off whatever this high quality video mode is and see if that makes a difference. Fibula, yeah, is the lateral malleolus. Again, so you can have a big avulsion, right? The hamstring tendons come down and insert on the fibular head, and you can have an avulsion where the hamstring tendon pulled a big chunk of bone away and the hamstring's not working. And so that would be a reason to try to go in and do surgery for it. But yeah, most of the time they're not touching They're not touching the fibula. Another new member, welcome. Joining just in the nick of time. We probably only got another 5 or so minutes left here. But feel free, welcome, ask questions. Let's run back here to some of these. Do sports teams have a dentist on call for dental emergencies? Yes, they do. Depends on the level. Like an NBA team has a dentist, NHL teams have dentists typically there, like at the arena, and can be extremely, extremely important and helpful. So yeah, teams have dentists that are helping them. Special tests before determining if she must have an external fixator. No, just they see the amount of trauma, they see all the swelling in the leg, and it's pretty clear, like, hey, we got a problem here. We can't put something permanent inside there. What are all these replies on here? Is this the same person that's replying to all these? Yeah, all right, cool. We're gonna hide this person from the channel. There you go. If you're gonna spam every single comment on here, you are getting hidden from the channel. Sorry. Yeah, good grief. Okay. We've kind of talked about the amino acids. Yeah, I think he'll be back next season. All right. How long until you see me on Dr. Mike's podcast? Good question. I'm not like... So I got to give props to Dr. Mike. I mean, he's like getting people on his podcast that are legit experts that like people want to hear from. And I'm not an expert. Like I'm good at teaching basics about sports medicine. I'm good at reviewing videos and understanding like mechanisms and injuries, and I'm good at kind of doing this simple sort of stuff. So if people found that interesting, great, but I don't think I necessarily like reach mainstream, like the people that he's bringing on there. So I'd be happy to, like, if he ever reached out and wanted to, I think it'd be great. I've done some stuff with him on some of his videos where he has like other social media physicians do things, but I've got a lot of respect for him. I'll admit early on, like in the beginning of his channel, I thought some of the stuff he was doing was kind of hokey and gimmicky. But I mean, like, he's done fantastic stuff recently. Like all of his like pushing people, challenging people on things, and really trying to be a good medical educator for the world is fantastic. I've got my little pocket over here with the sports medicine stuff. Great. I'm happy there. He can do all the other stuff that is way more beyond my understanding. So I don't know, be happy to sometime, but we'll see if he ever reaches out and wants to do anything. Thank you. I put a lot of time and effort into all this. Getting, lights all set up and tweaked, and we can change things, adjust everything, key light, camera, audio. Many years in the making. When I first started doing these videos, it took me like 7 to 8 hours to do one video, and now it's like 30 minutes, 45 minutes, because I've got my process so refined, and I can just kind of hit go. I know how to get my footage. I know how to, get everything pulled up and ready. So I enjoy it. I work a regular job. So I work 40 hours a week. I've got full clinic duties. I take care of a college sports team. And so these videos are like after hours stuff. Sometimes I'll run home over lunch if something's happened big in the morning. My family knows how much I love this and how good it's been, it's a nice little financial benefit too. And so they know, hey, 30 minutes, go knock out a video, helps grow the audience, helps support a little bit of revenue, keeps me building up this thing that I want to do, and they're all very supportive of it too. So it's great. Let's see. You are very welcome. Oh, I feel like I'm going to sneeze. Sorry. Been sick here. I'd love to get on one of the Ringer podcasts. The problem is the gambling stuff. I really try to stay away from the gambling stuff. I appreciate that my audience has allowed me to stay away from the gambling stuff, and that like nobody's begging me to talk about fantasy football and, give like exact prognosis and recovery times, because we know such a fraction of what's actually going on. Like, even if I come up here and predict and say, oh yeah, Micah Parsons tore his ACL, I have no idea what his MCL looks like, his meniscus, his cartilage, his everything. Like, there's so much more that we don't know. When someone's got an ankle sprain, we don't know like what specific ligaments, the severity, if there's underlying cartilage damage, tendon tears. We know such a fraction of what actually goes on, and I know that because I actually work and like do sports medicine and see all this stuff. And so it doesn't feel appropriate to be giving gambling advice like based on that. And so yeah, I just kind of have a hard rule that I'm not going to do any sort of gambling company ads. I don't want to be involved with fantasy football companies. I would still happily go on the ringer and do stuff, but I wouldn't want to do it in the context of like, okay, should I draft this player? Should I trade this player? What's going on? But I think there's still clearly a way to do it. I mean, I've built up this audience doing that without touching on the sports gambling stuff. And so, so I think that would actually be very good. All right. Specialized neurologist that practices sports or that, yeah, there actually is. There are sports neurologists. So you can do, I think they do like they're neurologists who then do like a specific sports fellowship where they talk about, it's a lot of concussion stuff, migraines, sports neurology, spinal cord injuries, brain injuries that can affect athletes. And so they're great. They're pretty few and far between. There's not too many of them. I actually, let's see, there's one that I follow on social media. Let me see if I can find him. He actually helped me with the case. He messaged me about something else. And, when I saw he was a sports neurologist, I was like, hey, while you're here, I've got some questions for you. Let me see if I can find it, because it'd be great to recommend to everybody if I can find him here. Let's see, is his page public? I don't know if his page is here. I won't be harming anything just showing this. This guy. Where'd that go? There we go. Yeah, Dr. Patel. So he, sports neurologist, works down in Texas, and that's what he does, is like sports neurology. So if any of you are on X, remember the question here was, sports neuro. If any of you are over on X, Twitter, check him out. Seems like a nice dude. Posts some stuff, about, I don't know if it's like centered all about medical stuff, but he is a sports neurologist. So it's a reference for everybody. All right. I think we are going to call it there. It's been an hour. Time flies. All right. Well, hey, thank you, everybody. All the new members that joined. Appreciate you all. Hopefully it was valuable. Get some questions answered. Have some good conversation. I am going to go head to bed. Clinic work in the morning. And thanks again, everybody, for joining. Appreciate y'all. As always, comments, questions, Discord's open, all that good stuff. And we'll see you next week. Same time, same place. Later.